So I heard a heart murmur. What do I do next?
Yeah. All right. Thanks, Josh.
That was nice to you, remember?
Great. All right, thanks for having me. I think we're going to challenge right after lunch here whether you can catch up on your sleep. So if you need to, take a nap after lunch, it's fine. And the other thing I had to do when I went for our break is I had to call my mom and see if she was using cocaine, because she is my daughter's grandmother. So I had to, but so far she said no, so we're good. So we're all caught up here. So we're going to talk about, this is kind of a lead into getting us into a different topic, right? We heard a lot about really everything that's important in cardiovascular medicine related to the treatment, diabetes, high blood pressure, cholesterol, markers, all these things. And valvular heart disease is going to fit right into that, right? So we're going to give you an update about where we are in valvular heart disease and the new treatment modalities that currently exist for patients with valvular heart disease. So the key is, what do we really do? I do research and things related to different aortic and other valve procedures. So for you to know right now, there are non-surgical treatments for every valve disease and every valve that we have, right? Most importantly, we hear a lot about transcatheter valves or maybe some mitral clips, but just know that there are FDA-approved valves to go in the mitral position, in the aortic position, pulmonic position. There are research-related valves that we can do. There are different clips, but there are non-surgical ways to treat most valve disease right now. And if you've already had a surgical bioprosthetic valve, we can put valves inside those valves as well. So there's many things that we can do now non-surgically. Just remember that the function of the valves that we have right now are really, let me try and get this fixed up here. The function of the valves are really just to maintain forward flow, right? They move with pressure gradients, right? When the pressure gradient is higher on one side than the other, then blood moves in that direction, and then the valves close and they're supposed to be competent. The treatment for most regurgitant valves, right, mitral or tricuspid regurgitation at least, is to try and reduce blood pressure and reduce the volume status of that patient. When you have stenotic valves, mitral stenosis, aortic stenosis, etc., those are difficult ways to treat those patients medically. A lot of those patients will need some sort of intervention to help that particular valve out, okay? So we look at the cardiac cycle, and there's different times when we think about the heart squeezing when valves are opening and closing, and this diagram kind of puts it all in line to what we might hear, what we might see, and what's happening on the EKG. So you can imagine it's a good place for us to harass our residents about labeling things, but other than that, it just intellectually puts things together to you and what's actually happening on each part. But valves do become abnormal, right? And if we think of the four different valves, and we'll talk about a few of them now, and the therapies that are new, even in the last year or so, to treat some of these things. So we know that valve stenosis, when we obstruct that flow, when we talk about certainly aortic valve stenosis or pulmonic valve stenosis, that we create a pressure gradient, right? The chamber that's below that valve has a much higher pressure than what's right above that valve. And when we talk about the left ventricle throughout the aortic valve, aortic pressures are much lower. Valves can be regurgitant, also called incompetent or insufficient, and a single valve can have both. And I used to have a line down here that said it's really hard or nearly impossible for patients to have critical or severe aortic valve stenosis and wide open or significant aortic insufficiency. Most of the times these patients will not do well. And I had a young man in my office the other day with both, right? He had a surgical valve replaced when he was in his 20s, did not want a mechanical valve. He's lucky that he has a wife and significant other at home that says, man, you're slowing down and you haven't seen Southard in a while. Maybe you should go see him. And his bioprosthetic valve is completely failed, right? He has a mean gradient across his aortic valve of 90 millimeters of mercury. And one of his leaflets completely prolapses and diastole, and he has wide open AI. So wide open AI and critical AS. And luckily, he's only 40 and tolerating it, but he's back to the operating room for him. And he still does not want a mechanical valve the next time around. He lives very, very, very remote and does not want a mechanical valve. But you can have severe AS and AI and still walk around. So there you have it. We know there's lots of things that can cause aortic valve disease. When you see patients with aortic valve stenosis, there's not a whole lot of workup you're going to do from a medical side of things to figure out what might have caused it. except asking what their travel history might have been. Did they ever have rheumatic fever when they were younger? Otherwise, not a whole lot of things you'll help figure out. Regurgitant lesions, any history of infection or endocarditis, bicuspid valves, rheumatic disease can all lead to progressive aortic and mitral valve disease. And our workup usually involves an echocardiogram to try and figure this out. Remember that the normal area of the aortic valve is about 2.5 to 3 centimeters at least, depending on the size of the individual. And the hallmark is this gradient, right? So if we look at the top, we have a catheter in the left ventricle and one catheter above the aortic valve in the aorta. And there really shouldn't be a gradient. The curves overlap because when the aortic valve opens, all the pressure comes out of the left ventricle into the aorta and there's no obstruction to flow. When the valve doesn't open very well, the curves down below, you can see the higher pressure is in the left ventricle and the lower pressure is in the aorta because there's obstruction to flow, the valve doesn't open, and the blood has to accelerate to get out of that valve. And this is the ultimate hallmark. So you can see patients in your office that have aortic valve stenosis, and their blood pressure could be 120, 130, 140, and you say, okay, we're doing pretty well. But in a lot of those patients, the blood pressure in their ventricle, every beat is 180, 190, or 200. So when you think, well, I'm not so sure why this patient is feeling poorly, every beat, awake, asleep, without exercise, at rest, that's what the blood pressure is in the left ventricle. And this is how we start to get the deleterious and detrimental effects on the left ventricle, then the mitral valve, then the left atrium, then pulmonary hypertension that eventually affects the right ventricle. And getting to these patients early on makes a difference. Well, we're seeing by what we're doing these days, by preventative medicine and not drinking out of plastic apparently, will help us live longer, right? People are living longer, right? With all the things that we do and all the therapies we have available to us, people are living longer. The population is aging, and with that will come the burden of chronic disease. And aortic stenosis will be one of those things. And the need to treat patients with aortic valve stenosis will be right there as well. So we know that the pathophysiology of this is a pressure overload state, so the left ventricle will become thickened, right? There's Laplace's law would say that if we look at that ventricle, the only way that we can decrease wall stress is to increase the thickness of the ventricle, because we can't change a whole lot of other things in that ventricle to decrease stress. So it becomes thicker in a pressure overload state, and we get marked left ventricular hypertrophy. And a lot of times when we do transcatheter or surgical valves, the ventricle itself, the cavity is very small because the ventricle itself is quite thick, okay? So that's how we deal with it. One of the things that we know after aortic valve replacement is you can't take a patient with aortic stenosis and leave them with significant aortic insufficiency. The ventricle is used to a pressure overload state. It's thick, it's not dilated and big. And if you leave them with aortic insufficiency, a volume overload state, the ventricle can't handle it, and those patients do not do well long term. Okay? So the natural history is that patients go along and develop progressive aortic valve disease over many years, and only after time will that valve become significantly narrowed enough that they start to have symptoms or begin to have symptoms. There are many patients that we see that don't just come in and this is the first time that they've ever been told that they have valve disease was a murmur that somebody heard just a couple weeks or a month ago. But this does not happen overnight. Eventually it leads to some subendocardial ischemia, chest discomfort, and if we wait too long, heart failure. And we've seen patients and seeing patients up here in Reading, and we get patients all over the place, but sometimes their first presentation is to the emergency room, to a local hospital, and the ejection fraction is already down to 20%. Their valve is critically narrowed, and we've missed the key times to try and make those patients better, right? The natural history looking backwards when Brunwald and colleagues initially started to look at patients with rheumatic fever and rheumatic heart disease is that patients started to have their symptoms right around the age of 60. And if they started to have symptoms of angina, syncope, or heart failure, and nothing was done, within 3 years, patients were dead. And this was the initial beginnings of what could we do for the therapy and treatment of aortic valve disease. Remember that most of the time that we use echocardiogram. And I would just tell you that when you see someone or get an echo on someone, there's a lot of information that comes across on that echo. But if you're looking at their aortic valve, if you focus just on the aortic valve area, right? There's pressures, velocities, gradients, there's all kinds of things you're going to get. But if you look at that aortic valve area, and that aortic valve area is less than 1.5, that patient already has the beginnings of aortic valve stenosis. And it's a good time then to get them to start seeing a cardiologist, right? Waiting till that valve area gets down to 1 or 0.8 or 0.6, we're already in trouble. They should already have established care, likely should have had something done earlier, right? I was at a meeting a little while ago and someone said, we should just set up a murmur clinic, right? If you hear a murmur, you get an echo, you send it to us, we'll figure it out, right? Because that's where we're going. We're waiting so long to treat patients with valvular heart disease. It's easy to check a blood pressure now. Whether it's accurate or not, we just figured out. But we have ways to try and treat it, right? But when valvular heart disease, people look at it, and unless that reading says something like, this is severe, this is critical, do something about it, you go, huh? The ejection fraction is 65%. It says they have moderate MR, moderate TR, moderate AI, but it's all moderate. We should be good to go. But we're waiting too long, right? The hearts are getting too injured, too dilated, too thick, and we should start treatment before, right? The management of asymptomatic aortic valve stenosis, we will now have the results coming up very soon of what to do with patients with asymptomatic stenosis. We know that we wait too long to either do surgery or other therapies for patients with valvular heart disease, and defining symptoms becomes very challenging as patients get older, right? If you're 75, 80, 85, and you tell your doc, well, I'm just slowing down, I'm a little fatigued, they go, yeah, you're 82 years old, right? But the valve disease underneath that could be contributing just as much as some of the other things that we're trying to treat. And you're less likely to try and put someone that's older on a treadmill or walk them or try and take them up a flight of stairs, right? One of my patients, we diagnosed with valve disease when we had a routine fire drill, right, at UC Davis. I'm seeing the guy for the first time in clinic, and I'm like, all right, I'm going to take this guy up the back stairs. Well, he did not do very well at the top of that one flight of stairs. I can tell you that right now. And we just admitted him to the hospital, and he had left main 3-vessel disease, right? One flight of stairs. We almost hurt him, but one flight of stairs, and you figured out a lot, right? Fire drills, not all that safe sometimes. So here's the malignant natural history of patients who are supposedly asymptomatic that have severe aortic valve disease. If you get your valve replaced or taken care of up top versus not. So patients that have supposedly asymptomatic severe aortic valve disease, it is a deadly disease. We know the guidelines are likely to change coming up, that we're waiting too long to try and treat these patients, or we're doing a very bad job in figuring out who's symptomatic. We don't want to wait for all these other valves and the pressures to be up on the right side of the heart and everything else before we start to deal with it, before the patient starts to have symptoms. So we know that the farther along we get in these stages, the worse these patients will do when they eventually get their intervention. So treating patients very early on when there's no cardiac damage makes the most sense. But the treatments we have to be easier for those patients, and they have to be durable. If we put someone earlier in their life through a procedure that doesn't have a durable result, we better know what we're going to do. So now it's called the lifetime management of patients with valvular heart disease. The decision you make today is going to affect the decision you make 10, 12, 14 years down the line. So we have to know what we're going to do. So this trial is finished. It's done enrolling. We took asymptomatic patients that we put on a treadmill over the age of 65. They had to pass their treadmill. And half those patients got a transcatheter valve. Half those patients waited till they had symptoms and then got a valve done. And we should have the results of this trial soon. We've already done follow-up. It's a 5-year extended follow-up to see, hey, who while waiting had problems, who got admitted, who had heart failure, who died, versus who got their valves up front and how did they do. But I'm certain that in the future, we will be able to treat not only severe asymptomatic aortic valve stenosis patients. We have ongoing trials of patients with moderate aortic valve stenosis. We have ongoing trials of patients with LV dysfunction and mild to moderate aortic valve stenosis. And I think the unloading the left ventricle and the treatment will change to earlier on, right? This is a patient that's young guy, doesn't want to have surgery yet. He said, I'm doing great, doc. I can do whatever I want, right? You put him on a treadmill, and he gets marked ST segment depression, right? Marked ST segment depression. And we're just a few minutes into a modified Bruce, which is a flat ground you start, treadmill test, and this is what he gets. And I go, all right, we're done. And even 10 minutes later, he's not back to baseline, right? So he's already beginning to get the stress or subendocardial ischemia and things like that. And he went on, he had a surgical valve replacement as a young guy, and he's like, I've never felt so good. I didn't know what it was like to feel this way because I thought I was doing great, and now I know what it's like. And this is even in young, healthy people. He was still doing a lot, right? But we know that just sometimes putting patients on the treadmill or doing some things can make a difference. We know that all patients who undergo surgical or transcatheter valve therapies should be seen by a heart team. They should be seen by everybody to determine what the best strategies for these patients are. Surgically, minimally invasive surgically, structural heart-related, endovascular. So they all should be seen by a team. When we do transcatheter valves, this is an Edwards Life Science valve here. It's mounted on a balloon, and we use that pigtail catheter, remember, to help identify where the aortic valve is. We have a pacing wire in the right ventricle. We pace the heart quickly, and then we inflate that balloon to help expand the valve. We move the old valve out of the way, and then the new valve starts to open and close. And, Scott Clark has got a lot of heart models in his car. He's willing to give everyone a heart model. He just doesn't know. He's got so many, they're door prizes now. And if you want to talk heart valves, he'll do it with you outside. Yeah, you might miss the rest of the session, but he'll talk to you. So that's what it's like, right? And that's what it's come down to. But when we first started to do patients, everyone had to be very, very, very old. And now really any patient can be evaluated for it. But we shouldn't be taking 50-year-old patients with bicuspid valves and doing transcatheter valves. We need good surgical things done up front, and then maybe a transcatheter valve later on in life. So we need to listen up front. Every time you see your patient, listen with the intent to hear that there's something going on in their heart that we didn't pick up, someone else didn't pick up, or you didn't pick up last time you listened, right? And then we decide who gets things done. This is our transcatheter group up here. Jessica's in charge of everything. And Aazib Khan, who is up here, did all of his structural training, has been doing transcatheter valves for 1.5 years or 2 years with us now, is a huge addition to the team up here. And Oz makes the program work with Jessica. I could tell you, I come up and they have everything set, and this crew up here can do things extremely well. And Oz is a huge addition to that team and does an excellent job. So now I just stand around and drink coffee. I don't even drink coffee. I wish I drank coffee. But very good team, very good team. So let's focus on aortic insufficiency, right? So aortic insufficiency is really the opposite of that stenotic lesion. It's a valve that doesn't close appropriately, either because the aorta is dilated or the valve itself is dysfunctional. And we get leak. The blood you just kicked out now leaks right back to you in your left ventricle, right? It leads to a volume overload state. And the way that the ventricle deals with that is by dilating, getting bigger. And if we wait long enough, the overall ejection fraction will go down. It's working to take all the blood that just came in through the mitral valve into the left ventricle, kick that blood out, and then all the blood that just came back to it through the aortic valve, it has to do again. So this is a volume overload state. If it acutely happens, because something happens to the valve, it gets infected or we have something that happened, the left ventricle hasn't had a chance to dilate or accommodate, and patients go into heart failure. This becomes a surgical emergency. We have to go in and fix that valve, or they're not going to do well. Acute pulmonary edema, they get intubated, they're going to have something fixed. Chronic, slow progression leads to LV dilation. The left ventricle can handle it until a point where it can't. And then we end up with heart failure or a drop in the EF. There's a broad range of things that could cause regurgitant lesions, including previous infections, different related to a rheumatic fever or arthritis or lupus or things that can affect the valve, things that can affect the aorta itself, make the aorta dilate, pull the leaflets apart, and cause aortic insufficiency. So there is a little more workup that's done in patients with pure aortic insufficiency to try and determine a cause, see if anything is modifiable, and then go from there. But again, the natural history of most of these patients is they get along with this regurgitant lesion, which may be mild, then moderate, and may never progress to severe. I have many patients that I've followed for the last 20, 22 years at UC Davis who have never had to have their valve replaced, and they still only have 2+ or moderate aortic insufficiency, and they may never have to have anything done. Aortic stenosis will progress no matter what you do to this point. We've tried to do other kinds of different medications to treat aortic valve stenosis. That valve will get worse every 6 months, every year, no matter what you do, and they are looking at getting a valve replacement at some point. But aortic insufficiency, not the case. This is how long we allow the left ventricle to kind of dilate in patients with aortic insufficiency. And the bigger we let the ventricle go compared to the patient's body side, the less likely they are to survive without some sort of intervention. And again, currently our guidelines today suggest you let the ventricle dilate, let it get bigger, let it get even a little bigger. But when it gets really big, then maybe do something about the valve. Because our only options previously were surgical valve replacement and valve durability. So if we can work on valves that can last, bioprosthetic valves that last 20, 25, 30 years, then why not do something earlier? we're going to head that direction. So right now, we do exercise people. We try and take patients to the operating room earlier. When is that key time? Still being determined, but there's a lot of ongoing trials. We know even if you have aortic insufficiency that's severe and the ejection fraction starts to drop at all, no matter what the dimensions are, you should have your valve replaced. Instead of waiting for the end systolic dimension to be 55 or a diastolic dimension to be 75 millimeters. That's a big ventricle. And then you hope that it'll remodel after the surgery. We're doing some detrimental things, I think, to our patients right now. But these are the guidelines. I think they will change in the future. I will tell you that there are percutaneous ways to fix valves that have pure aortic insufficiency. The Jenna valve and the J valve, right? The Jenna valve has already completed their Align AR trial and published the results. And this will likely allow us to treat patients with aortic insufficiency who are at high risk of surgery. And the J valve will have their trial upcoming shortly. This allows us to treat patients that don't have this stiff stenotic valve, but pure aortic insufficiency. It has these little graspers and ways in which it can grab the leaflets and hold itself in there and fix the aortic insufficiency. So there's still work to be done, early trials, first generation valves, but this is absolutely the future. My good friend Dr. Singh does a lot of work on mitral and tricuspid valves, and he was kind enough to talk me through some of our mitral and tricuspid stuff I'm going to show you, which has again been revolutionized recently in the things that we can do for patients. So we don't see as much in this country mitral stenosis, but when you do, it's almost always related to rheumatic fever, rheumatic stenosis. Some of my colleagues who still go back to India to do other work say, listen, they're doing like 8 to 10 to 12 mitral valvuloplasties every 2 days. If you want to go, they do like 25 mitral balloon valvuloplasties like a week. It's like their diagnostic heart caths. So like if you want to go do some more mitral balloons, why don't you come over with me for a week or two and you can do like 30, 40, 50 and then come back. I'm like, all right, seems like it's still a problem there. But for us, mitral regurgitation is more common than mitral stenosis. And people can go from acute mitral regurgitation, patients that might have mitral valve prolapse, who rupture a cord, who have a flail leaflet, who have an infection, or have a delayed presentation from a heart attack. They get ischemic, the papillary muscle ruptures, and they go from a competent mitral valve to a wide open mitral valve, and those patients will need something done right away. The heart can't handle acute changes, it handles chronic changes. So chronic mitral regurgitation is usually treated medically. We lower the blood pressure as low as we can, 115 or less, obviously, for everything, right? It allows us to push blood forward and not backwards. So that will help treat. We diurese, and eventually we follow the LV squeeze, we follow the dimensions, we follow symptoms, and eventually patients need to have something done. Now again, a lot of these patients sometimes are older. They're 78, 80, 85, and a surgical approach might not be the first thing that they want to have done. So we have non-surgical ways to do this. When medications fail and they need some sort of therapy, we have ways to treat it. So we try and figure out, first of all, when you have severe mitral regurgitation, which is a diagnosis which is echo-based for right now. Remember, ultrasound only, no radiation associated with that echo. Becky says she'll scan your patients all day, every day, like every day if you want one. Yeah, shoulder-related injuries, yeah. So we look at the left ventricle. Is it getting bigger? Is it dilating? Sam will push the machine around for her. I saw you say you'll push the machine, yeah. So is the left ventricle dilating? Is there left ventricular dysfunction? Is there anything else going on that would make us want to treat that patient, even in the absence of symptoms? If we see changes to the left ventricle, those patients should have therapy. So you will get a lot of echocardiograms in your practices. Patients you'll see, it'll say, oh, severe mitral regurgitation. Patient says, I'm doing great. And you might just say, okay, well, I'll just see you back again. But what is the overall ejection fraction? How big is the ventricle? Does that patient need therapy before something bad happens to the heart itself? We really should get those patients looked at, right? So a lot of times we do the same thing. We put them on a treadmill. It is interesting, though, that if you look at the guidelines to treat patients with mitral regurgitation, we only wait for the ventricle to be about 40 millimeters and not 55 millimeters before we do something about it, right? Different valve, different guidelines, different therapies based on what needs to be done. But I would just tell you to simplify it. Again, it's like Murmur Clinic. You hear a murmur, you get the echo, there's valvular lesions, at least send them over to be seen. What can we do for the patient now, and what should we be looking for in the future? Well, the mitral valve is much more complex. than the aortic valve, and the tricuspid valve is way more complex than the mitral valve when we think about what we need to do, how it's anatomically put together between the leaflets, the cord, the papillary muscle, and the left ventricular dimensions. Not only that, and the atria itself. Is the atria dilating? Is the annulus dilating? What's happening to the ventricle or the valve itself? Primary mitral regurgitation involves things that happen to the valve itself. There's something with the valve, the leaflets or the cords or something that are causing the problem, causing the leak, not allowing us to coapt. And secondary is what we call functional mitral regurgitation, is that there's something wrong with the left ventricle. That can be previous ischemia, previous MI, the left ventricle is dilating, whether it's ischemic or non-ischemic dilated cardiomyopathy. We're pulling the annulus apart, the leaflets get pulled apart, they can't coapt, and there's just a gap, and blood just goes back to the left atrium every time that the heart squeezes, right? So blood ends up going backwards. And that's an ultrasound of a patient with and without their Doppler on, and that light the beam torch right there is mitral regurgitation going back up to the left atrium, right? Just failure of these leaflets to coapt. And we will certainly help you figure out what the primary etiology is of that mitral regurgitation, but you can't imagine that that amount of blood going backward with every beat you have is somehow good in some way for patients, right? It's just not. And doing therapies for these patients early on, right? Early on, we had procedures where we could go through the interatrial septum to the mitral valve and put a little clip and try and clip the anterior and posterior leaflets together. And this initially on was considered kind of a bailout procedure, right? We would do this for older patients who couldn't have anything else done, but patients would always have residual significant mitral regurgitation, 2+, 3+ mitral regurgitation, right? This is a 90-year-old lady that, again, we managed to see, and family's like, I don't know, she's 90. What can we do to possibly help her, right? But she's pretty short of breath. She can't do much of anything. And you can go in and put a couple of clips in there, and you effectively create a double orifice mitral valve. There's now two little openings for blood to get in, and then blood doesn't leak backwards because the area that was prolapsing or torn is now clipped in the middle, and patients still do fine. And patients can go from having, significant mitral regurgitation and horrible heart failure symptoms to being back out and doing what they want. And even at 90, it's a 2-hour procedure, 2-hour recovery, overnight stay, and home the next day, right? So a lot of these times, patients can do well. The complication rates are quite low. TEER is kind of transcatheter edge-to-edge repair. And now we have mitral transcatheter edge-to-edge repair and tricuspid transcatheter edge-to-edge repairs. But the complication rates are quite low, especially in centers that do it all the time. The most recent, newest data that we have with the newest design clips show that 90% of patients, again, are leaving with 1+ or less mitral regurgitation. So a vast improvement from where we started. And patients can do quite well, less heart failure symptoms, et cetera, et cetera. So a lot of our older patients who might need more than one valve taken care of, now this is a treatable, something that's very treatable with durable results. So if we look at patients that have secondary, not primary mitral valve disease, how do they do? Well, we give patients the best guideline-directed medical therapy they can be on. They see a heart failure expert. That heart failure expert says, this is all I can do. They're on the best therapy I can. What if we clip those patients and they do better and live longer with a mitral clip in place? So, but you've got to be on the best medical therapy. This is a guy that couldn't even walk on his initial visit, couldn't even really get out of his chair in a wheelchair, and his 30-day visit, he does 1,450 feet on his 6-minute walk test, right? So when everything's just pushing back, it's like every step he was having before was heart failure, and now he's cruising up and down. So it can make a big difference for patients, right? So I always say if we think the patient has a salvageable condition, we should try and do something to help them out, and they'll tell you how much better they're going to get, right? There's complicating factors. If someone is on 6 liters of oxygen from end-stage emphysema, they're still going to be on 6 liters of oxygen from end-stage emphysema. So we have to look at those patients and say, how much can we help each individual patient, and is it worth any risk? What about patients that have all this dense calcification, right? This is more than just calcium in your coronaries. The mitral annulus is all white and all calcified. This is really impossible to operate on. You can't cut, suture, sew. What you get is the atria and ventricle separate from each other. You start to make incisions that cut through here, and you have a patient who will not survive the surgery. So these patients who have mitral regurgitation or stenosis related to mitral annular calcium don't have a lot of options, right? We can't be narrowing down the orifice more with clips, but we do have ways. We have ways that we could use this. If you look at this, it almost looks like a mitral ring or 3/4 of a mitral ring that you could use surgically. So what can we do? In research trials, right, we have valves that we can go in and put in through a transcatheter means and sit right on that mitral annular calcium. So we can go through the interatrial septum, put our valve right through that mitral valve and deploy our valve inside of the patient's native or normal aortic valve, move it out of the way, and it hangs in there. Right? It's using that dense calcium related at that mitral annular level to give someone a brand new heart valve. Okay, and the technology continues to get better and smaller and more applicable to more and more people who didn't have any options before. And if you look down on that valve to the left versus the right, the one on the right, you're like, oh, it almost looks like a surgical valve got put in there, right? Because it is a nice, big, open orifice now for patients. But again, we have to screen these patients as part of clinical trials right now. But there are things that are coming that we can do. Tricuspid valve, right? The tricuspid valve, the forgotten valve, until you have a therapy for it, and then everyone's very excited about the tricuspid valve again, right? So then interventional cardiologists go, whoa, the tricuspid valve, when did that become part of the heart? All right, now we can start taking care of things. All right, we can do something about it. So again, we still try and treat patients with diuretics up front and blood pressure control and things like that. We do our workup, but now we have ways that we can fix it. If we look at the surgical literature of patients who go to the operating room for aortic or mitral valve disease who have significant tricuspid regurgitation, the vast majority of patients don't have the tricuspid regurgitation treated. It's just not dealt with. That's the other side of the heart. So there's a lot of patients that have tricuspid regurgitation that eventually leads to ascites, lower extremity edema, right heart failure, and we have ways to recognize this up front and treat it. And tricuspid regurgitation has not only like 4+, it's like 5+. They call it torrential, like hurricane, cataclysmic. I mean, they put all these, delineations than just more than 4+, but just horrible leaks and blood going backwards and patients feel poorly. So we learned a lot about the tricuspid valve now that we're interested in it, but most of them don't have 3 leaflets. Only about half do. Some have 2, some have 4, some have all kinds of these other different, more than 4 leaflets. So there's all kinds of different ways that we're learning about the tricuspid valve now that we have more ways to fix it with minimally invasive surgeries. So we can use a specifically developed clip now that's now FDA approved and made specifically for the tricuspid valve in patients that can get clips. The vast majority of patients versus best medical therapy reduce their tricuspid regurgitation from this massive or torrential down to trace or mild with clips. And again, first generation, getting better at using it. You can put on a couple of clips and these patients can now be treated and it's much better than medical therapy itself. So these things are out there. This is just a patient up above before and then after, all the substantial leak they have before and just minimal to no leak after. And again, not an overtly high risk. It's a venous procedure up the inferior vena cava into the right atrium, looking down the tricuspid valve and back out, not even with an arterial stick. So a lot of just venous things that you can do. Edwards also has now an FDA-approved tricuspid valve replacement strategy, right? No longer in research. We were happy enough to be part of the pivotal trials and put these valves in the tricuspid position, right? So we now have valves that, again, going up the inferior vena cava from a femoral vein approach, we can make our way up into the right atrium, and we'll show you how we put this valve in. If it doesn't play fast enough, we'll skip through. But again, we're making our way in into that right ventricle, and it's not too hard to get the proper angle. And you're gonna place this valve inside from the bottom up, right? You make sure you're not caught on any cords. It has these little grippers and things that allow us to kind of get underneath the valve itself, hang on to it, and then kind of deploy this valve right in the middle. That allows us to treat patients with significant tricuspid valve disease who would not otherwise be a surgical candidate. So we can kind of set this valve in there, ultrasound guided, release the valve, and we'll deploy it here in a sec. For dramatic effect, it takes longer apparently, so it's almost deployed. And then I'll show you what it looks like after, okay? So these valves are now specifically designed to go in the tricuspid position. So we have ways, and again, I didn't even show you, there's FDA-approved pulmonic valve therapies, mitral valve therapies, tricuspid valve therapies, aortic valve therapies. So the minimally invasive endovascular treatment of valve disease is here and will only continue to get better. Medical therapy is still the first line. You do everything you can to identify patients first, get them on the best guideline-directed medical therapy you can, but an early referral to cardiology to begin therapy and treatment or continue therapy and treatment is what's really going to save your patients in the long term so they don't show up with actually bad ventricles or actually in heart failure. So this is part of the TRISCEND trial, showed marked reduction in tricuspid regurgitation and improvement in symptoms in patients by the way they walk, et cetera, et cetera. So more to come. This is now FDA approved, just coming out on the market, and therapies will continue for patients with tricuspid valve disease. Okay? That's what they tell me it looks like up here. That's what it is. Yeah. Thank you very much.
Thank you.
Mm-hmm.